Thank you for allowing me to present. It's great to see all the residents here. I have no disclosures. So for you guys, as you rotate through pediatric surgery, right, biliary atresia is very much a classical pediatric surgery disease, right? Unexplained neonatal jaundice, huge differential. But sometimes within the first couple months of life, bilirubin starts to rise, stool colors turn lighter and lighter, and this is due to some sort of unknown mechanism where bile ducts slowly fibrose over time, eventually leads to cholestasis, fibrosis, hypertension, cirrhosis, and eventually, if untreated, will lead to liver failure and death. Biliary atresia is like the leading cause of pediatric liver transplants, and the incidence, depending on what you look at, is anywhere from 1 to 10,000 to 1 to 20,000 births, and its most common prevalence is in Eastern Asian countries like Taiwan and Japan, which is why it's not a surprise that the surgery that you guys are all been sort of taught, the Kasai's procedure, is from a Japanese surgeon named Morio Kasai, who developed this in the 1960s. First treatment of biliary atresia brought over to America. It took us about 10 years for us to actually get sort of comparable results. But it's the portal enterostomy, and basically what you do is you dissect out the fibrosed biliary tree, and you do a Roux-en-Y anastomosis directly to the portal plate, leading to drainage of the biliary tree from these microducts because the large macro biliary tree has all been fibrosed away. Now, the unfortunate aspect of Kasai procedure is that even in the best of hands, even when you look at the Japanese data, which is the best, right? Because they treat this the most, the failure rate is pretty high, right? So when you guys kind of come through for rounds and things like that, we tell you, 1/3 of these will succeed over the course of lifetime. 1/3 will drain bile, but then will need a transplant. And then 1/3 just won't work at all, right? And if you think about that, that is a pretty poor rate for a surgery where you're basically making a huge subcostal incision. You're rerouting a Roux-en-Y anatomy for a neonate, right? And so it's a high cost for a surgery that in the best of numbers, if you look at Japan, success of a lifetime rate, probably around 60 to 70%. So even then, when those surgeons are treating those patients, you're still going to get about half these patients needing liver transplants over the course of their lifetime. So the only true prognostic factor that will tell you if you're going to have success is do it younger. Do it as young as possible, because probably the theory and the correct thing is that there's less fibrosis when you go in and you do the Kasai procedure. Unfortunately, biliary atresia takes a long time to diagnose, right? The workflow it takes to diagnose biliary atresia takes time, right? You want to get the correct diagnosis because there's a lot of reasons for neonatal jaundice, right? And so sometimes you just don't have the benefit of getting these patients when they're really, really young. So the Longacre Laboratory has developed an extracellular matrix ultrastructure quantification pipeline that looks at these whole image slides and looks at 147 different features of extracellular matrix, and includes different things like fiber length, fiber width, thickness, a bunch of things that, frankly, you're probably not super interested in. But the bottom line is it'll produce a pipeline that illustrates progressive changes in the extracellular matrix that can be used to look at the trajectory between what's healthy, normal tissue, and diseased advanced fibrosis. Previous applications that the Longacre Lab has used this for is for skin scarring and most recently pediatric pancreatic ductal adenocarcinoma, where they can look at the stroma of the PDAC and correlate it with overall disease-free survival. So given that biliary atresia is a fibrosing disease, and our close proximity to the Longacre Lab, we were actually wanted to determine whether we could use this algorithm for biliary atresia. And so in our retrospective cohort study, we sought to apply this comprehensive ultracellular matrix algorithm to profile liver fibrosis at the time of Kasai procedure and generate an architecture and a score, and can we predict which of these patients will do well and which won't? So the nice thing about this is it's a retrospective study, so we didn't have to wait years and years for accrual of patients who get biliary atresia, because frankly, no center for pediatric surgery across the country gets a ton of these, right? We get roughly about 3 to 5 a year. For any sort of numbers that can give us any sort of strength in our data, we'd have to wait several years. Fortunately for us, we can just look back at the slide mounting of the time of the Kasai procedure. For control specimens, we obtained patients without biliary atresia who underwent liver biopsies or resection for non-fibrosis indications like hepatoblastoma. And for what's called high fibrosis, we took patients who went straight to liver transplantation because their fibrosis was so severe. So these biopsies and sections from the liver were scanned, tiled, and then quantified for these 147 features. And then basically they are reduced down to a UMAP, which is sort of a fancy way of saying it's really, you can map data into 2 dimensions. You can even map data into 3 dimensions. Like it's sort of, you can sort of see what, mapping data into 147 dimensions impossible, right? And so what a UMAP does is takes all these variables and just sort of says what's similar to what. You can group them into like, okay, this is kind of in a group, this is kind of in a group, and this is kind of group out of all these 147 characteristics. So in terms of our methods, to say it was a successful surgery, patients are stratified in 2 groups comparison, whether or not they've been listed for transplantation at the time of surgery, right? Because so we went with list time because if we went with transplantation time, that much more depends on organ availability and whatnot. So if they're listed, we basically said, okay, that was a failure, right? Secondary outcomes is here. We're determined if the Kasai failed at 3 months. And this is, you know, due to things like if the bilirubin doesn't fall below 2 after 3 months after surgery, portal hypertension, GI bleed, the normal stigmatas of liver failure. As said, one of the big advantages of the study is we're able to use existing pathology and the existing workflow to go back. There was nothing special we needed to do. We just need to retrieve the slides, scan them, and then we can look back in their chart for all the data sets that we needed. Mason's trichrome, if you can remember from your medical school days, from your histology classes, uses 3 particular dyes to study fibrosis and the abnormal deposition of collagen. And so, you know, it looks at collagen, muscle fibers, and so it's a really nice ideal way to look at fibrosis. And so then the algorithm looks at those 147 distinct parameters, like fiber width, length, packing, alignment, and once again, other stuff that you aren't super interested in, but the algorithm looks at. And then we use this algorithm to apply what's called a pseudotime trajectory, which is a great way of looking at a static image by putting out what's normal, because for us, we can't get a bunch of biopsies in sequence, right? That'd be great if we could like biopsy someone at the time of surgery, then biopsy someone a month, and then biopsy someone 2 months, right? But that's not really practical or ethical or safe, right? And so what pseudotime does is allow us to form a trajectory based on a root normal tissue and then see, depending on the variability, where we think that they are fitting on the fibrosis tree. And so these are the patient demographics of the cohort which we accumulated over a 5-year span. And we got 12 samples, 5 which were listed for transplant and 7 which were not, which is pretty much in line with the national data. And there's nothing remarkable about this data set, except we did have a little slightly increased levels of cholangitis, which nobody take a look at. It's kind of embarrassing. This table shows the image tiles that we got from each sample and the control. And so then, you know, we're interested, what does data show? Once again, we took these 147 variables, put them into a UMAP just to say a look. And basically what you can see here is that on the top left, the low fibrosis control, yellow is where they're clustering, right? And so the low fibrosis control, which means the hepatoblastomas, the liver biopsies that don't have really any fibrosis, they all clustered over there on the right side of the graph. The high fibrosis control, which is so much fibrosis they don't even qualify for a Kasai procedure, all clustered onto the left, as you can see. And then what we looked at was who's listed and who's not listed. If you look on the bottom left, the not listed are sort of clustering more towards the low fibrosis control, and the listed for transplant are clustering more towards the high fibrosis control. So that was very positive for us when we looked at that, in terms of like, these are grouping together. Then we next use pseudotime on all the images, and we basically were able to use a dynamic dimensionality reduction tree algorithm, which fancy way of saying, can we score these things, right? So looking at all these factors, can we assign a score and say this is the number, because we all like numbers to be able to sort of parse out the data. And so low score, good. 0, no fibrosis. And so high fibrosis was assigned a score of 60. And So for all our cohort, the mean score was 29.6. But if you look at the two differences between listed and non-listed, the non-listed group, the ones that are still doing well with their Kasai procedure, was 22.9, but the listed group was 35.9. So a clear difference up towards the higher fibrosis. Patients with, so then we had to sort of decide what is a cutoff number, right? That would make us that people love one single number to say, we should do this with this, we should do this not with this, right? And so what we did was, with our data set, we picked the 75th percentile. So a median biliary atresia extracellular matrix score of 41.3, which is a 75 percentile, we termed high risk. And those below 41.3, we deemed low risk. And when we looked at the data in terms of their survival, there was a significantly decreased native liver survival when compared to low risk biliary atresia scores. When you look at particular subgroups of 147 characteristics, a couple did stand out. High Euler numbers was repeatedly found to correlate with lower scores, which means less fibrosis. So higher Euler numbers meant lower fibrosis. And higher scores, meaning higher fibrosis, was correlated with several different things like high binary convex, grayscale convex. Once again, won't go into super details because that's not relevant to the audience that I'm talking to right now. But these particular factors of our algorithm meant that you could correlate these with our biliary atresia score. And most importantly, this is the graph here, right? The high-risk biliary atresia extracellular matrix score on biopsy at the time of diagnosis was associated with significantly decreased liver survival, with a mean date of 123 days, right? So within 4 months, almost all of these Kasai procedures had failed, right? And so for the ones that survived, we can't really give you a time when they failed because they're still going, right? And so they're still going, and hopefully those fall out into the lifetime people who survive, right? And so in summary, based on these analysis, this multidimensional quantification of liver fibrosis could be a powerful prognostic tool for patients with biliary atresia. And most importantly with this, we found that our score was not correlated because we just happened to have all our low-risk patients be the youngest patients, right? That'd be one way to skew the data. And next, we looked at how our score compared with single-factor fibrosis analysis, like utilizing collagen percentage alone. And we found that while both did correlate, ours scored higher in terms of association and between looking at this sort of specialized test. In addition, ours, as I'll talk about later, has a much more simpler overall protocol. And so we feel that our algorithm has the ability to capture the complexity of tissue fibrosis in a more comprehensive clinical manner while being much more simpler for every institution who are doing these surgeries to actually capture. So finally, what we did was we blinded a pathology expert in biliary atresia and assigned Medivir scores. And Medivir scores is basically a way for pathologists to grade liver fibrosis. And when we blinded, there was no statistical difference that they could tell between the listed and unlisted. And so in conclusion, the C grant allows us to develop a method that can analyze fibrosis and biliary atresia in a comprehensive systematic manner. And most importantly, already uses protocols that every pediatric surgery center that treats biliary atresia already uses, right? So there's nothing special that needs to be done extra for them to run this algorithm. And not only that, since it's an algorithm, you don't need any special pathology skills or any additional training needed to be able to run this, right? So a lot of these barriers for these special stains and things for prognostication is that whether you need expensive reagents or you'll have site-to-site variability because you need to train pathologists to be able to read these things, that kind of goes out the window. We have one set of standards already within the pathological workflow that can hopefully be used to stratify whether or not a patient will do well with a Kasai procedure or whether they will not. So in terms of return on investment, we've actually just been accepted to Annals of Surgery. And this is, you can read the article actually online, and it'll come out pretty soon in the journal form. And this is a huge picture of Nora, which I'm sure she'll be embarrassed by. But like, this is pretty much the brainchild of Nora, who will be joining our residency program here coming up in the summer. And I just want to shout her out in particular because it's her effort, her sort of will to be able to get this whole protocol off the ground. That's sort of, I think, a model for how residents become surgeon scientists, right? It's basically her persistence and her intellect that got us all to the ground. And for me, she has a really promising career in academic surgery and shows for you guys or anybody interested in, you know, people tell you nowadays, it's hard to be a surgeon scientist, it's impossible, right? That's not true, right? You just need to have the right infrastructure that I think this department provides, and you need to have the right willpower to be able to see these things through, because this is frustrating for her. Like, she had to get everything off the ground by herself, and so big shout out to her. And so where do we go next? So a limitation of this study is obviously numbers, right? We can only accrue a certain amount of numbers per our institution, right? 3 to 5 a year. So we presented this at the Western Pediatric Surgical Research Consortium, and for internal consortium reasons, they decided not to take up the project. But each individual institution was so interested that we've already got accrued 5 to 6 programs that are actually already sending us their slides. So now we are going to a multi-institutional way, and so that we can increase our numbers and basically, hopefully, get a large enough cohort that we can start to make some really definitive statements about how we can risk stratify biliary atresia and whether or not the Kasai procedure will be beneficial or not to these patients as well. In addition, we are also trying to look at the actual root cause of biliary atresia. So with this, we have looked into some of the single cell data about the fibroblast. We are now looking at spatial transcriptomics with the xenium, and that's pending. And so hopefully we'll be able to give you more data in terms of the actual pathological reasons behind the fibrosis for biliary atresia in the future. Obviously, a lot of work has gone into this, cooperation and funding. I'd just like to really thank the surgery department. It's getting harder and harder for younger researchers to do research. And so this C grant and the support is invaluable. It would not be possible without it. Thank you.